here we go, completing a wonderful day. It's been a great day, yes? Everybody's had a good time? Good. Doctors are judged based upon how low they make numbers in their patients. Their bonuses, their salaries are tied to how low they can make hemoglobin A1Cs and blood sugars and cholesterols and blood pressures and how many tests they order and so on. That's what the business is all about. It's about numbers. Well, I as a doctor, I can't do it single-handedly, which is the point of our next guest, but I as a doctor can make your numbers as low as I want. I can make your cholesterol 30, which would be, by the way, about 1 international unit. I can do that, I'm a doctor. But I can't do it alone, which brings our next guest into the picture. I can make your blood pressure 40/20, but I can't do it alone. I can write a prescription that will do that. I can make your blood sugar so low that when you stand up, you will fall on the floor and split your head open. I can do that, but I can't do it alone. I must have help. And our next speaker, he can't do it alone either. He has to have help. He must have me and other physicians take out a piece of paper and write a prescription. And then he, not alone, he has to rely upon the drug companies to provide the product to answer that written letter that I sent to a pharmacist. And oh, it must be terrible to be the middleman. Dustin Rudolph, would you come up and tell us just how much fun you have in life as a drug no, you're not. You're a plant pusher. Welcome.
Thank you. Thank you. Well, Dr. McDougall is right. I can't do my job without him. And it's been an interesting journey with my career. First of all, I just want to tell you guys I'm from Florida. And when Dr. McDougall emailed me about 10, 11 months ago, saying, would you like to come and speak at my conference? And of course, I'm like, yes. And then 5 minutes later, I realized it was in February, and it was in Santa Rosa. And Santa Rosa's in North California. And I'm like, then I went on weather.com and like looked at like what the low temperatures were like. And it said 30s and 40s. And I'm like, oh my God, I have to go buy a coat now. So here I am. I bought a coat, not this coat, but I bought a coat, and here I am. I'm delighted to be here. Thank all of you for being here, because I always say that people spend their time, energy, and money on the things they value the most in life. And just by you guys being here says that you value your health and your future. So thank you guys for being here, and thank Dr. John and Mary McDougall for having me and the team. And I'm going to talk about diabetes today. So it's called a lifestyle medicine approach to preventing and reversing type 2 diabetes. And I have a sneaking suspicion that between me and Dr. McDougall, you're going to get a double dose of some of this, so we're going to beat it into your head. So I hope that you find it helpful. So I thought I'd start with just a little bit about myself. Because some of you might be familiar with me, some of you might not. But I'm known as, my name is Dustin Rudolph. I'm a PharmD. I'm board-certified pharmacotherapy specialist. So I got my board certification this past year. At the end of April, I took the exam. Only, I think, 7 or 8% of pharmacists nationwide are board certified. I'm a real pharmacist. I really do pass out pills and IV medications. I work full-time as a pharmacist. I actually work in the hospital setting. I work 7-day on, 7-day off schedule. I work overnights, so my sleeping schedules flip back and forth. Dr. Dysinger might not be very happy with my sleeping schedule. But I do work in the hospital setting where the acute crisis happens all the time. I started my career in retail. So I graduated in 2002 from North Dakota State University, so from Fargo, actually where Dr. Neil Barnard was born, and went to school there for 6 years. It was way too cold there. I mean, it's not, like here it's cold, but up there we get like 60 below wind chills in the winter, and it's just unbearable. Your hair like freezes as you're walking from the door to the car. So don't go up there in the winter. Go up there in the summer if you go up there. But I graduated in 2002, and then I was working for a big box pharmacy as an intern, pharmacy intern. I decided to stick with them, and I wanted to move south because it's way too cold up there. So I moved to St. Louis, Missouri for about 3 years, and I still worked in retail. I hopped from one big box pharmacy store to another, and I was not happy. I was very frustrated because there's a lot of stress. Your patients keep coming back. They keep getting worse. You just keep them full of pills. You keep handing out more pills and more pills and more pills, and their prescription list grows. And then on top of that, you're fighting over who's going to pay for what with the insurance companies and the patient and then the doctor and the prior auths and all this stuff. And nobody really talks to one another in that in our healthcare system. So it's very frustrating, to be honest with you. I was still way too cold in St. Louis, so I decided to move south to Florida. I live in the Tampa Bay area, Tarpon Springs to be exact. So for any of you that have been to the Tampa St. Pete area, it's a little Greek community up there. I had no idea it was Greek when I moved there, but I do now. I continued to work for a grocery store pharmacy. Switched pace a little bit slower pace, more patient-centered as far as having my time to spend with the patient. And I found that I continued to be frustrated, and I'd go home stressed out and frustrated, and I was like, this is just not working for me. I have to figure out something else. So one of my best friends in pharmacy school, he actually went into hospital pharmacy right after he graduated, and actually as a student intern, he was a hospital pharmacy student intern. And this is about 5 years into my career. And he said, you really need to make the switch to hospital. You use more of your clinical knowledge. You're going to feel like you're actually accomplishing something at least. And I was like, well, I've been out 5 years. I forgot a lot of what's in school. I'm probably not smart enough. And he's like, BS, go for it. You can do it. So I made the switch to hospital. That was in 2000 or towards the end of 2006, so almost 5 years into my career, about 4.5, 5 years into my career. And I've been in hospital ever since 2006. So that's what, 10 and a half, 11 years? And basically what I treat in hospital is acute crisis that's going on. The heart attack that comes through the ER, the diabetic that comes in with diabetic ketoacidosis and almost in a coma, the stroke patient that comes in that is now half their body is numb and they can't function. So I treat a lot of that. I help the physicians and the nurses and the rest of the team in the hospital treat a lot of that. As far as food goes, I was born and raised in Montana on the standard American diet, meat and potatoes. Southeast Montana, Baker, Montana. I don't know if anybody's ever heard of it. It's a really small town. But we're in the middle of farm country and oil fields. And all we know is cattle ranching, farming like wheat, but it's not for humans. Usually they send it off the asparagus crops and those kind of, the alfalfa crops and the wheat crops and that kind of crops. They go to animal feed. So it's all about cattle ranching and that form of agriculture, not about fruits and vegetables. I was in 4th grade when I decided to be a pharmacist. Most people ask 4th graders what they want to do, and they're like, I want to go play baseball, or like, I want to be a race car driver. Not Dustin. Dustin says, I'm going to be a pharmacist. Actually, I said, I'm going to be like Todd. I live in a small town. We had 1 doctor. We had 2 pharmacists in the whole town. So we had 2 pharmacies. They were each owned by a separate pharmacist. Todd was our pharmacist. I loved him to death. I looked up to him every time we went into the pharmacy. So I wanted to be like Todd. And I told people in 4th grade I was going to be like Todd, grow up and be like Todd. And here I am, 20 years later or so, or 30 years later, and I'm like Todd. I didn't learn about whole foods, plant-based nutrition until about 8 years into my career. I was ignorant and stupid. I had no idea that the food that you ate affected your health. Not a clue. Because they don't teach this in pharmacy school. They don't teach any of it. In fact, the only nutrition training that I had in pharmacy school was called total parenteral nutrition. Anybody heard of total parenteral nutrition? A few of you have, probably in the medical field. That's when you go into the hospital and you can't eat for some reason. Maybe you have a bowel obstruction or you have bowel surgery or something like that. And so we make up a solution full of dextrose, proteins like amino acids, and fats, lipid emulsions. And we make this big old bag up, a 2-3 liter bag. And what we do is we hook it up to the IV and we give that food basically through the arm. It's not a good way to eat. It's not very good nutrition, but it can keep people alive. So that's really the only nutrition training I had in school. I had no idea that what we ate as far as whole foods affected our health. And then I also love animals and the environment and our planet because we're only given one planet. We need to take care of it and the environment that goes with us. And then I learned about the animal part after I started eating this way for my health. I have 2 little rescue cats right there. Sony, right here, this little guy. He just naturally poses like that. I don't know, maybe he's trying out for Hollywood or something, but this is Sony and this is Reese. I got them both when they were 1 year old. They were adopted. I rescued them, and they're about 12 now. So they're really like family to me. This is my grandpa. Now, his real name is Francis Ferdinand Rudolph. Nobody calls a little kid Francis Ferdinand. So they had to nickname him. They gave him the nickname of Rudy. So he's my Grandpa Rudy. He's a World War II veteran. He worked in the oil field for 30-plus years, much like my dad, who just retired about 1.5 years ago. Yeah, my dad worked in the oil field for somewhere between 25 and 30 years. So I come from a family of oil field workers. I was the first one to go to college. In retirement, my Grandpa Rudy had an 80-acre estate. So it was about 25 miles, 30 miles south of my hometown. And people call it the end of the earth because Ekalaka, Montana is about 9 miles away from him. And Ekalaka, they say, is like the end of the earth. There's literally nothing there. They don't even have any stoplights or anything. But he was close to a town. He had an 80-acre estate. 5 acres were corn and potatoes. So we would go and harvest these potatoes and corn every year with him. So I know that would make that 5 acres of potatoes, and he had a big, huge root cellar that he stored all these potatoes in because one person can't possibly eat 5 acres of potatoes. But he would make Dr. McDougall very proud. My grandpa loved his potatoes. He also had 2 large vegetable gardens. He loved gardening. He loved to grow things. And then he had Easter chickens. He called them his Easter chickens. So he had all these chickens on his farm, and they would lay, not the white eggs, but they would lay the light brown eggs, the light green eggs, and the light yellow eggs. So he called them his Easter chickens. But my grandpa, despite eating a lot of vegetables, a lot of corn that was grown in his own backyard, and a lot of potatoes, still suffered from type 2 diabetes, heart disease, and eventually he died of colon cancer. He spent the last 8 years of his life suffering in misery, taking all kinds of pills. I remember his kitchen table full of medications, and I was too young at that time because he died in I believe it was 1993 or 1994, and his kitchen table would be full of prescription bottles. And I remember him giving himself insulin shots. So despite eating all these vegetables and potatoes and corn and stuff, he loved meat. He ate meat all the time. So he would wake up and he'd have half a package of bacon and 3, 4, 5 eggs and ham and sausages for breakfast. And then he'd turn around and eat, lunch meat sandwiches. And then for dinner, he'd have a big old steak. So he did eat a lot of vegetables, but he ate pretty much the standard American diet other than that. He didn't eat processed foods, but he still got the standard American diseases despite eating all those vegetables. This is a picture of my grandpa and me. That's me, right there, on his farm in Montana. This is one of his vegetable gardens right here, and they were huge. They were probably at least a half an acre themselves. Down beyond this hill right here was 5 acres, his 5 acres of corn and potato patches. So that was my summers spent in my grandpa's farm. It was very fond memories that I had, and I love him to death, but he died of the same things that everybody else dies of in this country. So as type 2 diabetes, it's really a disease of choice. And I want to drive that point home. This is a dietary disease. This has nothing to do with having bad genes or what your family history was or something else. It's really a disease of choice. It's the food that you put into your mouth. So you are in charge of your own destiny. And it really comes down to the food. It's all about the food. And the more colorful you make your plate, the less of a chance that you're going to end up with this disease. And type 2 diabetes is a terrible disease. I wouldn't wish it upon my worst enemy. There's so many complications that come with it. And they take people, they rob them of their time, their health, their money. It's really a bad disease. So you got to get this under control right away as soon as you can if you get diagnosed with type 2 diabetes or prediabetes. So a little bit of data here. I know Dr. Dysinger talked about this a little bit. But about 12 to 14%, this is 2012 data, 12 to 14% of the population has diabetes. About 9% of those are diagnosed, and then another 3 to 5% don't even know they have diabetes. So they're just walking around not knowing that they have it. Another 37 to 38% of adults have prediabetes. So like Dr. Dysinger talked about 1 of every 2 people have prediabetes or diabetes. So if you add this up, about 12%, about 38%, that's roughly 50%. Think about that. When you walk down the street, if you don't have diabetes, the person you're looking at probably has diabetes or prediabetes. It's really a growing epidemic, and it's something that we have to get control under. It's the 7th leading cause of death in the United States in 2014. Actually, it's the 8th leading cause of death, because the leading causes of death is a big lie, because the 3rd leading cause of death is medical error, which is me and the rest of the doctors and pharmacists and healthcare providers out there, but they don't put that on the official list. So I just wanted to let you guys know that the 3rd leading cause of death is me. So this is really the 8th leading cause of death if you were to do the statistics right. The predictions are with the baby boomer population coming up. We have a plethora of diseases coming up, and diabetes is one of them. Now, in 2009, we had about a little bit over 8 million people with, in the baby boomer population with diabetes. It's predicted that in 2034, that's going to almost double to 14.6 million people with diabetes. That's a lot of people to take care of, and we're just throwing pills at this, and it's not working. So I wanted to go over a little bit of the cost of diabetes. And in 2012, I got some data. We spend a lot of money on diabetes, $245 billion total in direct and indirect cost. So that includes both medical care that we use on diabetes, like pills, procedures, surgeries, hospital visits, ER visits, doctor's visits, and then indirect costs, which include like transportation to get to the hospital or the doctor's office, or missed time at work, or all those things that you don't think about, but that do cost money. Can you imagine what we could do with $245 billion extra, especially since this is a dietary disease? If we could just wipe this off the face of the planet with a plant-based diet, we could do a lot of damage with an extra $245 billion. That equals $8,400 roughly per person who's diabetic, diagnosed with diabetes, and about $800 per person for every man, woman, and child in the United States whether they have diabetes or non-diabetes. Who would like another $800 in their checkbook every year? Wouldn't that be great? And that could happen if we didn't have this disease, and this disease doesn't need to exist if we eat the proper foods. So I wanted to figure out, kind of put this in perspective. So I was like, $245 billion, yeah, that's a lot of money, but like you and I, we won't even see that kind of money in our bank account ever. So like, what can we, compare that to? So I looked on the same year in 2012 at the amount of money that the US government allocated to the transportation and the education industry. And the transportation industry got a budget of $93 billion. The education industry got a budget of $103.3 billion. So if you add those two up, 93 plus 103, that still doesn't equal $245 billion. So we spend more on diabetes in this country than we spend on our schooling for children and our roads and bridges combined. And I just saw the other day, actually there was an article that I read, I think it was about a 4-year-old article in Florida. It says you can take PE online now. Why are we giving PE classes online? I mean, maybe we should have less diabetes and more money to convert to the education system so we can hire some actual PE teachers. That would be good. But yeah, you can take PE online. You're supposed to like run around the block and measure your heart rate before and after and then put that in the computer, and then that's how you pass the class, I guess. But it's crazy to see how our society has developed and what we value in life. Okay, since I'm a pharmacist, I have to talk about the drugs. And when it comes to diabetes, a lot of patients are on medication. About 85% of them are on medication of some sort. Now, for every diabetic patient, there's an average, they take an average of 4.1 prescription pills for their chronic disease, whether it's, a lot of them have heart disease and other diseases with it. So for every diabetic, they average about 4.1 meds per person. And then when you add in the over-the-counter meds on top of their prescription med, that average goes up to about 5.8 meds for every diabetic person. 57% are on oral meds only, about 14% are on insulin, and then about a little bit over 14% are on insulin and oral meds. Now how this works is the typical patient will go to their doctor, and their doctor will diagnose them with diabetes. Maybe they'll get an A1C test or a fasting glucose tolerance test or some kind of test like that. And they'll get diagnosed with diabetes. Their doctor will say, well, you've got diabetes here, so what I want you to do is, you need to eat better. So you need to lose some weight, because usually they're obese or overweight. So go home, lose a little weight, eat better, eat your fruits and vegetables, and come back to me in a month or 3 months, and we'll see how it goes. So they go home, they eat their apple a day, and they try to move around, get to the gym. Maybe they lose a couple pounds, 2, 3 pounds, 5 pounds. They come back, and their doctor tests them again, their blood tests and their sugars, and they're still diabetic. And the doctor goes, well, that didn't work, so let me get out my prescription pad here and write you a prescription for a diabetic med. So we're going to start you on oral meds now, and then eventually you get started on oral med, and they go through the same song and dance for another 6 months or a year, and then they come back, and then things are getting worse, and then the doctor says, well, let me give you another prescription here, because that one's not working, or let's up your prescription dose. So they get another prescription, they go to their pharmacist, they fill it, they do this song and dance again for another 6 months or a year, and then eventually they come back and they say, well, the oral meds aren't working, we're going to have to give you insulin. And that's pretty much par for the course for diabetes. And then what happens after these pills fail people and the insulin fails people is they get all these problems right here. All these complications with diabetes. So you're almost guaranteed that if you have diabetes, eventually you're going to get heart disease. Pretty much guaranteed. So you're going to get high blood pressure, you're going to get high cholesterol, you're going to get heart disease, just like my grandpa. Another problem is your kidneys start to fail. Eventually your kidneys will fail, and a lot of diabetics have to end up going on dialysis. And I don't know if you know anything about dialysis, but dialysis, your whole life just completely changes. 3 days a week, you have to go to a dialysis center for 3 to 4 hours at a time, and you have to get your blood run through this dialysis machine to take out all the toxins and other crap that's in your body that your kidneys not filtering out, because your kidneys don't work because you have diabetes. And you can't really travel, or if you travel, you got to make sure that you have everything set up for another diabetes or dialysis center, because your kidneys don't work, and you can't go more than 1 or 2 times without having dialysis during the week, or else you're going to end up in the ER and in a world of hurt. So kidney disease is really a terrible problem that comes along with the later stages of diabetes. Another one is blindness. Diabetic retinopathy is one of the complications of diabetes, and it's one of the leading causes of blindness in America. So these people with diabetic retinopathy, eventually they'll go on to develop diabetic macular edema, which is some swelling on the back of the eye, and you start to lose vision, and some people go completely blind. So that's another problem that they have. You get nervous system damage. A lot of diabetics will develop peripheral neuropathy. It's where the ends of your fingers and your toes start to get numb, and you start to lose feeling, and then you can't feel anything if you step on a nail or run into a corner on the kitchen stove or something. You can't feel that stuff. So then what happens is these diabetics, they have to check their, you've probably heard that diabetics need to check their feet all the time, every day, because a lot of them have this nerve damage. They can't feel the bottom of their feet, so they step on something. They get a wound. They don't know that they have this, and then a week later, a month later, they have this wound that's out of control. Now they have they have to go to the doctor, or they have to go to the emergency room because their foot is completely infected, and now it's maybe gangrene or on the way to that. So the nervous system damage is real, and it affects people, and it's another complication of diabetes. Skin infections and skin ulcers, that kind of leads into the nervous system damage. So these diabetics will come into the hospital all the time. They'll have diabetic ulcers on the bottom of their feet or other areas of their body. We'll have to treat them with IV antibiotics because their infections are so bad that they couldn't do it with oral antibiotics. They went to their doctor. They got oral antibiotics. They didn't touch them. So they come to me in the hospital, and then I'm mixing up IV antibiotics for them. Limb amputations. Diabetes is the leading cause of non-traumatic limb amputations. So if it's not due to an accident or a trauma, it's the leading cause of limb amputations in people. And then dental disease is another complication. Pregnancy complications. Diabetic mothers who are pregnant can develop preeclampsia. That's where the blood pressure skyrockets. That's not good for the baby. It can also cause birth defects, some heart defects if you're diabetic for your unborn child. So some very serious things there. And then diabetes, it just runs down your immune system. You're more apt to get infections and get sick during those times of year. And then people who are diabetic often become depressed. And I can imagine why, because if your whole life is turned around with your health and you can't do the things you normally do, you're going to get depressed. And then for the men in the room, you also become impotent. That's another bonus. So diabetes is really a nasty disease. It's not something I'd wish on my worst enemy. And you really have to nip it in the butt as soon as it comes along. Now, I kind of threw this in there. I wanted to make sure that all you men knew that Tuesday was Valentine's Day. So don't forget. And this is Diabetes, True Love in the Titanic. It says, if you truly loved me, you'd swim back to the ship and get my diabetes medication. So are drugs the answer? No, they aren't. Drugs are usually not the answer for most chronic diseases at all. They're a Band-Aid. They can help you manage the disease, and that's what we usually talk about in conventional medicine. When you go as a patient to your doctor or your pharmacist, we can tell you, we can give you all these pills, all these prescriptions, all these IVs in the hospital. We can help you manage your disease, kind of get you back to normal, I guess, the American normal for health, but you still have the disease. If you're managing the disease, you still have the disease. And I don't know about you, but I've never met a person in my life, a patient in my life, that wants to keep their disease and just manage it. Why do that when you can just get rid of it? So drugs just help manage disease at best. They really do nothing more. They perform well below expectations. I'm going to get into that a little bit later, and I think you're going to get a heavy dose of that from Dr. McDougall tomorrow. So they don't address the cause of the illness. And I'm going to talk a little bit more about that with diabetes too. They only suppress the symptoms. So we're great. As a pharmacist, I'm great at suppressing symptoms. I can cover stuff up for you in the short term, as much as you want. But it doesn't do anything long term, 5, 10, 20, 30, 40 years from now. So drugs are not the cure that everybody thinks that they are. There's no magic pill. Okay, this is really, 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 really important. So if you don't understand this concept, I'm going to explain it to you, and you need to understand it because it's so important. I'm going to talk about how statistics are reported out there in the media and in the scientific literature and what this all means. So you guys have all seen the commercials in between the nightly news that says, take our medicine, it decreases heart attacks by 35%, 40%, right? Or stroke risk goes down by 40%, or yada, 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 it goes down by 50%. Well, what is that actually, where is that statistic coming from? What does that mean? What is this drug actually doing? How do they come up with that? And what I want to drive home is the difference between absolute and relative risk reduction. This is extremely important. So let's say that I'm Dustin, I want to invent this drug to treat diabetes. So I'm going to invent drug X. And of course, whenever you invent a drug, if you're a patient taking a drug, I would assume, hopefully, rightfully, that you're going to take this drug, and the reason you're taking this drug is because you don't want to die, and you don't want to get one of those complications of diabetes, right? What we focus on in medicine, usually, to sidetrack people, is this drug will reduce your blood sugar by so much. This drug will reduce your A1C level by so much. But I don't know about you, but I don't care about that. What I care about is not dying and not suffering from a major complication of a disease. So let's say I make this drug X for diabetes. And so my goal is to reduce diabetes-related death. So before I can bring this to the market, I have to go to the FDA with a clinical trial to say that this is safe and effective. That's why the FDA is there. So I'm going to take drug X, and I'm going to get 200 people in my study. I'm going to put 100 people in this arm of the study, and I'm going to give them drug X. I'm going to get 100 people in this arm of the study, and I'm going to give them a sugar pill, a placebo. And then I'm going to follow them for 5 years, and I'm going to see who died of diabetes, a diabetes-related death. Fair enough? See how my drug works? Let's say that after 5 years, in my drug group, 2 patients die from diabetes after 5 years. In my placebo group, 4 patients die of diabetes after 5 years. Did the drug work? Yes, the drug worked. Because 2 patients is less than 4 patients, right? So the drug did work. So what does this mean? Well, if you're watching TV, this means that it led to a 50% reduction in diabetes-related death. How do they come up with that? Is 2 half of 4? Yeah. So really is a 50% reduction in diabetes-related death. Was there more than 6 people in the study? Of course there was. So if you just forget about the other 194 people, you have a 50% reduction in diabetes-related death. And that's called relative risk reduction. And that's how statistics are reported in those commercials that you see on the TV and in the magazine ads. And that's what drug reps talk to doctors about. In fact, one of my good friends that I just met is a drug rep, a former drug rep, that left the industry because she's found out about whole foods, plant-based diet and preventing and reversing chronic disease. Her name is Vanessa Sardi, S-A-R-D-I, and I actually interviewed her for my website. My website's plantbasedpharmacist.com. If you go on there, her interview is called Confessions of a Former Drug Rep, Vanessa's Journey from Pill Pusher to Plant-Based Healer. And I asked Vanessa, I go, when you go into doctor's offices, which one of these statistics do you talk about? And she goes, oh, relative risk reduction. It was always relative risk reduction. We would never talk about absolute risk reduction. I go, well, did the drug companies train you on what the difference was between relative risk reduction and absolute risk reduction? And she said, well, no, that we learned all about relative risk reduction. That's what we knew. That's what was drilled into our head. So when we went to doctor's offices, that's what we told them. We told them relative risk reduction. And doctors are so busy nowadays, they don't have time to read through the literature, a lot of them, unless you're Dr. McDougall, and actually take the time to do it. So they rely on the drug reps to do this. So if you think I'm outspoken with what I'm talking about, you should read her interview because she goes into way more detail into what happened in the pharma industry. So anyway, back on hand here. Absolute risk reduction, really in this example, there's a 2% reduction in diabetes-related death. Now, how do we get that 2%? Well, 2 out of 100 is 2%. 4 out of 100 is 4%. So if you take everybody in the study and you look at how this drug worked, you go from 4% to a 2% reduction, or 4% to 2% people who died of a diabetes-related death. What's the difference? 4 minus 2, that's 2%. So you see how that works? You could play around with the numbers and you could get wildly different results that you could report with the same drug. So what I'm telling you is when you hear stuff about how drugs work and how successful they are, what you're hearing is 50% reduction. This is really a distortion of the truth. I guess I just call it lying. Big Pharma is lying to us. They're telling us this number when we should be knowing this number right here. So be careful. So now I want to go into some of the drugs that we use to treat diabetes. And I'm not going to tell you the relative risk reduction. I'm going to tell you the absolute risk reduction because that's what I think people care about. That's what I care about. So metformin is one of the first drugs that we put people on. It's an oral anti-diabetic drug. And it works primarily by reducing glucose released from the liver when we eat. So when we eat, you're getting all the glucose that you need from the food that you get. And normally, any extra glucose that you would not need at that moment is packaged up into little glycogen balls, and the liver stores these glycogen balls. So that when you don't eat, you still need energy, and what the liver does is it breaks down these glycogen balls into little glucose and it puts it out in the bloodstream so that you have energy while you're not eating. Well, metformin helps to reduce the amount of glucose that's outputted by the liver, which, I mean, that would make sense if you want to treat diabetes. And then secondarily, it also decreases glucose absorption in the gut, and it increases insulin sensitivity. But these other two are just minor actions of glucose or metformin. It mostly works by the liver. So how well does it work? So over 10.7 years of people taking metformin, 6.3% were helped by avoiding a heart attack. Remember, heart disease comes along with diabetes most of the time. 10% were helped by reducing a diabetic complication, kidney disease, limb amputations, blindness, heart disease, those kind of things. And then 5%, a little bit over 5%, avoided a diabetes-related death. So for taking this drug, you get anywhere from about a 5 to a 10% chance of having a benefit from this. And you get about 2 to 12% chance of having some kind of GI side effects. So nausea, vomiting, diarrhea, extra gas. Metformin is known for having GI effects, side effects with, any drug has side effects, but metformin is known to really affect the GI system. A really rare side effect that happens with metformin is called lactic acidosis, but it rarely ever happens. If you look at the Cochrane collaboration reviews, it's almost non-existent in people with normal or mild or renal impairment. For people who have moderate to severe renal impairment, that's where you got to worry about not putting them on metformin because of the risk for lactic acidosis. Okay, moving on to the next group of drugs. I think this is probably Dr. McDougall's favorite anti-diabetic group of drugs here. Sulfonylureas, glyburide, glimepiride, glucotrol, those kind of drugs. The way that these drugs work is they basically tell the pancreas to release more, produce more, and release more insulin. So you have to take them prior to meals so that when you take it and more insulin is released into your bloodstream, that's the time when you need it. The insulin to work is when you have food in your body. So they work mostly on the pancreas. So how well do they work? So the UK prospective diabetes study lasted about 10 years. What they did is they took people and they put them on a sulfonylurea or insulin, and they compared that to a diet group. Now, the diet, there's about a little bit over 3,600 people in this study. The diet group, I looked up what kind of diet they put these people on. It didn't say specifically. All it said was they encouraged a low saturated fat, high fiber diet with about 50% of the calories coming from carbohydrates. Now, if I were to tell somebody walking down the street to go on a low saturated fat, high fiber diet with about 50% of the calories coming from carbohydrates, they would have no idea what that means. So basically, it's the standard dietary advice to eat more fruits and vegetables and lean meats is what it comes down to. And what they found is that in the drug group, they measured the HbA1c, and the HbA1c is usually a 90-day average for your blood sugar levels. So that's kind of the standard blood marker that we use for looking at these diabetic drugs and how well they're used. Remember I said the pharmaceutical industry likes to kind of sidetrack us and stuff that doesn't matter. So what they measure a lot of these drugs up against in their results on the studies is how much of a lowering effect they can have on HbA1c. And what they found with the drug, whether they were on sulfonylurea or on insulin, is that they had about a 7% A1C level, HbA1c level, and if they went on the diet, they had about a 7.9% HbA1c level. Now, the lower your HbA1c level, the better off you are. If you're less than 5.7, you're normal, you're non-diabetic. If you're between 5.7 and 6.4, you're pre-diabetes. And if you're 6.4 or higher, you're considered diabetic. So if you're at 7% or 7.9%, does it really matter? No, you still have diabetes. You can still suffer the complications of diabetes. And what they found was that the drug group did reduce the complications of diabetes, so like kidney damage, some peripheral neuropathy, some retinopathy, blindness by about 2.4%. So you have about 2.4% benefit when it comes to that. But there was no statistically significant reductions in death rates. So for taking these drugs, you get a 2.4% chance of reducing complications and a 0% chance of avoiding death. And of course, there's always side effects with all drugs. And so along with that comes weight gain. Any drug that increases insulin in the body will cause weight gain. Whether you give insulin in a shot or you take a sulfonylurea to tell the pancreas to produce and release more insulin in the body, as long as you're increasing insulin in the bloodstream, you're going to get weight gain. And the sulfonylureas led to about a 3.7 to 5.7 pound increase in weight gain. Insulin itself, if they gave it to the patients, was about slightly under 9 pounds of excess weight that people gained. Hypoglycemia is another side effect that can be very serious. You can end up in the hospital. It's low blood sugar. So your blood sugar basically crashes. You can go into a coma with that. So with these drugs, about 1 to 1.4% of people on a sulfonylurea got a hypoglycemic event, and about 1.8% experienced that kind of event with insulin. And with the diet, it was only 0.7%. So you get like a 2.4% chance of reducing complications and under a 2% chance of having a major hypoglycemic event, and then you're going to gain between 5 and 10 pounds. And you get no benefit for reducing death rates. Okay, this class of drugs, Victoza and Byetta is also in this class of drugs. These are called GLP-1 agonists. They're glucagon-like peptide 1 agonists. They work in multiple facets. They work kind of like metformin in the liver, where they tell the liver not to release glucose into the blood. They tell the pancreas to increase insulin production and release. And then they also slow gastric emptying. So that's how these drugs work. They are injectable drugs, so you have to give them as a shot. They're not a pill. And in a study on Victoza, after taking it for 3.8 years, about 1 to 1.5% benefited by avoiding either heart disease-related death or avoided death from any cause. And then about up to 1.6% experienced nausea, vomiting, diarrhea. 3% people had to have had gallstones. 0.8% needed the services of Dr. Van Dyken to remove their gallbladder. And then there's also post-marketing reports of pancreatitis with these drugs. So when you look at the benefits and the risk, you're actually more at risk of suffering one of these side effects, with gallstones and other problems, than you are of being helped. Now, I can't tell you if you're going to be in the 1.3% that avoids a heart disease-related death or 1.4% in that group that avoids a death from any cause. It's kind of like flipping a coin or playing the lottery. Nobody can tell you that. There's not a doctor on the face of the planet or a pharmacist on the face of the planet that can tell you if you're going to be in this group or this group or this group. This is a flip of the coin. So the next group of drugs that I'm going to talk about is the SGLT2 inhibitors. It's Jardiance, Onglyza, Farxiga. You've seen those commercials on TV where I think it's like the construction workers has this big old boombox on his arm, and he's dancing around and stuff, and he's saying that he takes his whatever it is, Farxiga or Jardiance, and that life is great. So these drugs basically work by telling the kidneys to filter out glucose so you can just pee out the extra sugar. Guess what the kidneys should never filter out? Glucose. There should never, ever, ever be glucose in your urine. A normal person never has glucose in their urine because it's fuel to the body. The body wants fuel. We don't want to waste fuel. You wouldn't put gas into your gas tank and then hope that it leaks out the side. I mean, you want to keep that gas in there. So our kidneys are brilliant. Our kidneys, when glucose gets filtered out in the initial stages, in the initial part of the nephron, it reabsorbs all the glucose back into our bloodstream before it ends up in our bladder and out into the toilet. So a normal, healthy person does not have glucose in their urine. So why don't we just make a drug to make us pee out glucose? Doesn't that sound great? We can treat diabetes that way. Well, that didn't work so well either. And actually, the numbers on this are even worse with the side effects than the previous group of drugs. So after about 3.1 years on Jardiance, what happened was about 1.5 to 2.5% of patients will see a benefit of this. About 1.5% avoid hospitalization due to heart failure, and then a little bit over 2% avoid a death either due to cardiovascular diseases or from any cause. So I don't know about you, but that's not a very good successful rate. The side effects are even worse. Look at this. 6.4% experience a genital infection, 18% experience a urinary tract infection. Guess what environment bacteria love? Warm, wet, and lots of food. Guess what environment they get with this drug? It's already warm there. It's already wet there. There's a bunch of urine. So why don't we just put a bunch of food in there? Make our kidneys filter out all this glucose. Then they're having a smorgasbord of whatever they want to eat. So that's why the yeast and the fungi and the bacteria and all these little critters love that when you take this drug, because they're gonna feed off of that, and then you get an infection. And then you're gonna have to go on antibiotics, and then the antibiotics can wipe out your normal gut flora, and then maybe you get C. diff, and it's just a snowball effect, like many of the other prescription drugs that you take. So you gotta watch out for that. So really, what are the causes of type 2 diabetes? It's certainly not because we don't have enough glucose filtering out in our urine. That doesn't cause type 2 diabetes. There's 3 main causes of type 2 diabetes, and I'm going to talk about each one of these. How many people have heard of insulin resistance? Almost everybody in the room. That's what I find everywhere I go, whether you're a layperson or a physician or a pharmacist or a nurse or a dietitian or no matter who you are, everybody's heard about insulin resistance. And they teach this very well in school, insulin resistance. So the body doesn't react to insulin very well. The second and the third cause, or the second and third contributors to type 2 diabetes are very important too, but they don't teach this, as far as I know, in medical school, and they don't teach it in pharmacy school. At least they didn't when I was there. Number 2 is an increase in intramyocellular lipids. These are little fat particles in the muscle cells, and I'm going to go over that. And then the third one is a reduction in peroxisome proliferator activated receptor gamma coactivator 1 alpha, which is known as PGC1 alpha, and I'm not going to pronounce it again because it's way too long and complicated. So I'm just going to say PGC1 alpha, and I will teach you what that is all about later on. So let's talk about insulin resistance. So normally when you eat, the pancreas produces insulin because it knows that you're putting food in the body and it needs to release insulin. And these insulin molecules go around and they work on your body's fat cells, and they work on your body's muscle cells, and they work on your body's liver cells. And these insulin molecules tell your respective cells to do certain things. Well, normally in fat cells, it tells the fat cells when you're eating, insulin will be released, and you don't want your fat cells to break down the fat to provide you energy because you're eating, right? So the insulin will tell the fat cells not to do that. But in a diabetic who has insulin resistance, that doesn't work. The fat cells keep breaking down the fat. It's called lipolysis. It's just a breakdown of fat, and keeps dumping that into the bloodstream. Well, you don't need that. That causes a problem. For liver cells, what insulin does when you eat is it says, if there's any extra glucose out here, you need to take up this glucose and put it in a little glycogen ball and store it for later use. Well, when you have insulin resistance, that doesn't happen. So what happens is your liver has glycogen storage already, has all this glycogen stored up in the liver, and it still releases this glycogen. It breaks down the glycogen called glycolysis, and breaks it down into glucose molecules, and it dumps it into the bloodstream. Well, you don't need more glucose into the bloodstream when you're already eating and you're intaking glucose. So that's a problem with insulin resistance. And then the third problem with insulin resistance is insulin tells your muscle cells to take the glucose that's in your bloodstream and uptake it into the muscle cells to use it as fuel. And in insulin resistance, that process is also messed up. So the muscle cells don't respond to the insulin, and they don't take up the glucose. The glucose stays in your bloodstream, and you have high blood sugar. Make sense? Okay, now this second problem that comes along with type 2 diabetes has to do with intramyocellular lipids. And I first learned about this through Dr. Neil Barnard. And when I learned about it, reading his book, I was like blown away. It was like a Nobel Prize moment for me that somebody came up with this. And learning the importance of how these intramyocellular lipids work in the muscle cells, I could not believe that this was not taught in pharmacy school and is not taught in medical school or even dietetic school. I don't think it's taught. I could be wrong, but as far as I know, in the mainstream medical education system, this is the most important thing that we can possibly teach physicians, pharmacists, dietitians, nurses, everybody, because it's the most important thing that causes type 2 diabetes in the first place. And so there's these little particles of fat that are inside the muscle cells, and they're used by the muscle cells when we're fasting as energy. And in type 2 diabetes, we have way too many of these little particles of fat. So I have a little diagram, and this is a normal cell. So this is a cell membrane right here, these two little blue or brown lines. This is the insulin receptor right here. Here's the insulin. So when you and I eat, our body absorbs the nutrients and breaks down the carbohydrates into glucose. Here's the glucose in the bloodstream. This is the inside of the cell right here. Insulin will come and attach to the insulin receptor right here. What happens is inside the cell, there's these little molecules or substances called glucose transporter 4, or GLUT4 transporters. And they're normally just hanging out in the cytoplasm in the middle of the cell here. But when insulin attaches to the receptor, there's a bunch of chemical messengers that get that signal, and they go over here to this GLUT4 transporter, and they say, hey, get your butt up to the outer membrane here, dock on the outer membrane, open up your doors, and then once that happens, let the glucose into the cell. That's how a normal person's cell works, muscle cell. This is a muscle cell. And these little yellow blobs right here, those are intermyocellular lipids. So when we're in periods of fasting or between meals, we need some of those for energy. This next slide is a diabetic's muscle cell. You see a difference? There's a big difference here. Look at all these little guys right here. All these particles of fat. There's way too many of them. And what the research has said and what the studies have said is that this basically just gums up the whole system. And nothing works right in our muscle cells. So what happens is, one thing that happens in animal studies, it's been shown that all these extra intramyocellular lipids that are in excess, they decrease insulin receptors by up to half. So you have less insulin receptors for the insulin to attach to. And then for the ones that are there, the insulin, it blocks the insulin from attaching to there. And then if insulin does happen to get through all those things and attach to the receptor, then it messes up this whole messenger system of telling the GLUT4 transporter to go from the cytoplasm up to the cell membrane and dock to let in the insulin. So there's multiple stages along the process that these little fats cause problems with. And one of the most problematic fats is called palmitic acid. And that fat is actually found mostly in animal foods, in meat, so beef, pork, chicken, dairy products, eggs, vegetable oils. So all the foods that you've learned that we should not be eating, that's where this excess of fat is coming from. It's not coming from a lack of pills. It's coming from our diet. So this whole process right here is totally due to our diet, and this is what causes insulin resistance. So insulin can't attach here, and the cell can't respond to the insulin. So we talk a lot about insulin resistance in conventional medical education, but we don't talk about what causes insulin resistance, and this is what causes insulin resistance. So if we can get to that, and we can't get to that with a pill, we have to do it with diet. If we can get to that, we can solve diabetes. So let's go back to some of these drugs I was talking about, because I want to see if any of these drugs target intramyocellular lipids in the muscle cells. So remember metformin? It works on the liver. It decreases glucose absorption in the gut, and it increases insulin sensitivity. Does any of that say that it reduces intramyocellular lipids? No. It doesn't work that way. The drug doesn't work that way. How about sulfonylureas? They tell the pancreas to release more insulin. Well, what good is that if we have a bunch of fat in our muscle cells that clog up the whole system. Now we have all this extra insulin that we can't really do much with anyway. So that class of drugs is out. Victoza, Byetta, these work by working on the liver, telling the pancreas to release more insulin, and then slowing gastric emptying, slowing the amount of food that kind of, like slowing down the food as it moves through the GI tract. Does that have anything to do with intramyocellular lipids? No, nothing. Jardiance and Farxiga and Invokana, these class of drugs, they tell the kidneys to just pee out extra glucose. So does that have anything to do with intramyocellular lipids? No, nothing. So none of these drugs, there's 12 classes of diabetic medications. Not a single class targets intramyocellular lipids. And even if we made a drug that did target that, there'd be a whole list of side effects that come with it. So the only way that you're going to get to the root cause of diabetes is by changing your diet. It's not going to come from a pill. And plus, these pills, you know, the success rates is what, 1%, 2%, 3% at best. And then you have anywhere from a 1 to 10, 15, 20% side effect profile. So they just don't work. The drugs don't work to treat type 2 diabetes. They're a Band-Aid on the problem. They do nothing to fix the problem. So the third part of causing type 2 diabetes, or a contributor to type 2 diabetes, is that PGC1 alpha. Now, some of you may have never heard of this. I read about it in an article, actually, that was talking about intramyocellular lipids, and I found it pretty fascinating. What PGC1 alpha is it's responsible for regulating energy metabolism. So it has everything to do with the mitochondria in the cells. And if you remember from 9th grade biology class, the mitochondria is basically the power plant of our cells. It produces all the energy. That's where we get our energy from. So PGC1 alpha is actually like the chief engineer in charge of building new mitochondria. So if you have this chief engineer building mitochondria, you can make more energy. And to make energy, you need glucose. Glucose goes through the Krebs cycle in mitochondria and comes out as ATP. So this is really a good thing with this PGC1 alpha. So in type 2 diabetes, there's a reduced amount of PGC1 alpha. So what happens when there's a reduced amount of PGC1 alpha? You have less chief engineers to make power plants, right? So fewer chief engineers to make fewer power plants. Fewer power plants means less energy is produced. And if you have less energy produced, you have less power plants to gobble up all that extra glucose to make the fuel in the first place. So that's another reason why type 2 diabetes, another contributor to type 2 diabetes is this reduction in PGC1 alpha. So what are we to do? Really, it comes down to doing the basics. It's getting your diet right and moderate exercise. So I like this little cartoon here. It says, don't worry about your dietitian finding out, Allison, what happens in Baskin-Robbins stays in Baskin-Robbins. So that means to adopt a low-fat, plant-based diet, much like Dr. McDougall talks about, Dr. Esselstyn, Dr. Barnard, all these thought leaders in this industry. It's vegetables, fruits, legumes, whole grains, really minimal nuts. If you have diabetes, you should have minimal nuts and seeds or none at all. You want to avoid all oils. Oils are 100% fat. They do nothing to help diabetes. And then you want to, like I said, limit nuts and seeds and avocados, because nuts and seeds are anywhere between like 70 and 90% of the calories are from fat, and then avocados are high in fat too. And the problem with diabetes is that extra fat in the muscle cell. You want to avoid processed and refined foods, and you want to avoid animal foods. So no meat, no dairy, no eggs, no processed vegan foods. Stay away from all that. Just eat whole foods. Eat real foods as they come off the tree, off the bush, out of the ground. That's what you want to concentrate on. And this has been proven to work. So there was a review of 14 randomized controlled clinical trials over a 10-year period, and they found that low-fat, plant-based diets actually were more effective than any of the other common diets used to tackle type 2 diabetes. Not only did patients have increased insulin sensitivity, but they had more glucose metabolism, and they, as a added bonus, they reduced their cholesterol levels, they reduced their A1C levels, they reduced their body weight, they lost weight. So it's a positive thing all the way around. And then moderate exercise. Make sure you move. Every single speaker up here today has talked about exercise. So it doesn't you don't have to be a world champion weightlifter, you don't have to run marathons or triathlons, but just get some kind of movement in every single day. You need about 30 minutes a day. And whether it's walking or you're in the weight room or you're biking or gardening or just something to move your body. That's so important. And the reason why that's important is because there's really two reasons. One thing is that it reduces insulin resistance. So it decreases insulin resistance. And then another thing exercise does is it's been shown in studies to increase PGC1 alpha. And again, PGC1 alpha is the chief engineer in charge of building more power plants, or your mitochondria, so that you can make more energy and use more glucose to turn into ATP. So moderate exercise is very important. So who's in charge of your health? You are. So you can go to your doctor can sit there and write all kinds of prescriptions for you. You can go to the pharmacy, stand in line, give them your insurance card, get all these prescriptions filled. You can go home, you can take the pills, but ultimately your health is not going to get any better by taking more pills. In fact, in the 15 years I've been a pharmacist, without fail, every time I see somebody's drug list grow, the longer it grows, the more miserable and sick that person is. I've never seen anybody reverse a chronic disease by taking more pills. Never, ever, ever. It's not how the body works. Right here? Okay. So eat the right foods, move your body, do the right things. And what I will leave you with is, here's my website, my book. I wrote a book called The Empty Medicine Cabinet. It's the Pharmacist's Guide to the Hidden Dangers of Drugs and the Healing Powers of Food. I go over a lot of these diseases, the heart disease, diabetes, kidney disease, autoimmune diseases, cancer. And I kind of talk about food versus medicine and treating these diseases. And there's a lot of information on drugs in there, how well or not well they work, all the side effects that are associated with it, some of the costs that are associated with it. So if you want more information, you can get that. And then my website, plantbasedpharmacist.com, I have a ton of articles on there. I believe in giving this information out for free because I think everybody deserves to have a healthy life, and getting the information should not be prohibitive in them wanting a healthy life. So, check out my website, and you can get my book if you want on Amazon or barnesandnoble.com or anywhere out there. And I'll leave you with this, is that we only have one life to live and one body to live it in. So make sure you take care of it. Thank you.
Thank you. Any questions? Oh, you have to come over here, please.
Well, you're lining up for questions. Excellent presentation. You prepared them properly for the more condemning presentation I'm going to give to the drug industry tomorrow. And I just did want to distinguish one thing for all the audience is the discussion has been on type 2 diabetes. I know you meant to say that. Type 1 diabetics absolutely require insulin.
Yes, that's a very important part,
Thank
Dr.
you.
McDougall.
Both of you, Dr. McDougall and Dustin, what do you do when you have a patient that's a type 2 that's taking medication and you change them? Do you change the medication? Do you wean them off of the medications, or do you try to go cold turkey? How do you recommend doing that?
Well, I don't recommend people change their medication just based on my advice. I always tell them to make sure they're working with their physician before they change any medications.
That's exactly correct,
it's
and
very,
I will tell
very
you
important.
exactly how to do it tomorrow.
Yes.
That's your question? I will tell you exactly how to stop the medication tomorrow. Could we have someone else? We have a couple more minutes. Yes, Dr. Dysinger. It's your mic.
So thank you so much. Great presentation. My question is around the length that diabetes has been in the system. So as I understand the literature, if we catch someone obviously in pre-diabetes or early diabetes, we can totally get rid of the diabetes. If someone's had it for 8 years, 10 years, 20 years, it's much harder. Have you seen any statistics, and I don't know if Dr. McDougall can comment on this too, the success of reversing diabetes if it's been in the system long term?
I haven't looked, it's a very good question actually, Dr. Dysinger. I haven't specifically looked for any of potential cutoffs on when type 2 diabetes is too far gone to start reversing. I would say that, really one of the concerns is, as you probably know, once you get these complications, once you go on dialysis, your kidneys are shot. Once you chop off a leg because of a gangrene foot or leg or wound that couldn't heal, you can't put the leg back on. You lose your leg, you lose your leg. Once you go blind, you go blind. So as far as what point that happens, I haven't seen anything specifically. Maybe Dr. McDougall has more information on that. I don't know.
I do.
Okay.
But you have to wait till tomorrow.
Okay. The suspense.
Dr. Rudolph, you laid the best foundation for the presentation I'd like to give tomorrow, and the questions that still remain unanswered. I hope I can get to all of them for you tomorrow, but I couldn't have heard a more thorough, easy to understand presentation of the topic than you presented today. To me, an expert can tell a story that all the audience can understand. People who don't know their subject confuse the audience. You did a phenomenal job.
Thank you.
Thank you very much.
Thank you.
All right. So Dr. Rudolph will be outside to talk to you for a few more minutes. Special guest speaker. Not going to happen because we had such a big day, but I do want to say just a couple words to you. Many of you got laboratory tests. Those laboratory tests are not specifically doctor prescribed. It's under the state of California that is information accessible to you if they are abnormal. We got cholesterol, triglycerides, cholesterol fractionations, and thyroid function tests. If they are abnormal, then you must talk to your physician, healthcare provider about what to do, what they mean, et cetera. Yes, you need to do that. And so that's what you do with the lab tests. Tomorrow, we're going to be starting at 8 o'clock. You think that we had an amazing day tomorrow. Challenge me. Oh, excuse me, today. Challenge me. Do you think we can do better tomorrow? Dream about it. We have an amazing dinner for you. Ladies and gentlemen watching from around the world, we will be back with you in a matter of just seconds for you, but in hours for our live audience. Thank you very much for a wonderful day. And Tiffany, what else do you have a couple lab tests, Tiffany? Is that what you're saying? If you haven't got your lab test, Tiffany will help you. Dinner is phenomenal. Talk to you in a few minutes. Bye-bye.